Good afternoon. It's my great pleasure to welcome you all to this educational webinar on legislation in Florida, implementing health care and Medicaid reform in the state. If we could move on to the next slide, please. My name is Vera Perez. I'm the Vice President for Health Initiatives at the Collins Center. And I want to welcome you on behalf of the Collins Center for Public Policy, where I work and which is bringing this webinar to you, together with the League of Women Voters of Florida. Just briefly, the Collins Center for Public Policy has offices in Tallahassee, Tampa Bay, Sarasota, and Miami. And we are a think tank devoted to finding smart solutions to the issues facing the people of Florida and the country. We are independent, nonpartisan, nonprofit, and passionately fit to lasting results. Sometimes, in fact, we've been called a think tank with muddy boots, working with community to find solutions around some thorny public policy issues. The League of Women Voters of Florida, which is our partner and co-host in this webinar today, is a nonpartisan political organization that works to encourage informed and active participation in government, working to increase understanding of major public policy issues and how these in turn can provide influence of public policy to education and advocacy. I need to provide a special thanks to the Florida League's president, Deirdre McNabb, who has worked closely with us in thinking about preparing this webinar primarily for the membership of the League of Women Voters together with the Florida chain. So thank you to Deirdre. If we can move on to the next slide, please. So in addition, I also need to welcome and also introduce our colleagues who will be presenting today. With us from Health Management Associates is Dr. Jack Meyer, Principal with Health Management Associates, which is a consulting firm. He's out of the Washington, D.C. office, but they have offices in 11 cities across the country where they work on consulting in the areas of health system restructuring, healthcare program development, health economics and finance, evaluation, data analysis. And there has been a great concentration as well on the needs of medically indigent and of late a great deal of focus on the new health reform legislation. With us from Florida Chain is Laura Goodhue, who is the Executive Director of Florida Chain, which is a statewide consumer health advocacy organization devoted to improving health of all Floridians by promoting access to affordable, quality health care. They also play a critical role in connecting consumer, community, and service organizations with healthcare advocacy. Next slide, please. So just before we get into the slide, a couple of housekeeping rules. I'd ask for all of those listening in, if you could, keep your phone on mute. You'll see that on the right-hand side of your screen, there's a little box, and it offers under your name the opportunity to push the mute button until we get into the question and answer piece. On the question and answer piece, we are going to leave these for the end. We hope to have somewhere between 15 and 20 minutes left for questions. At that time, we'd ask that you write your questions into that sidebar, and we will take them as they come in. Hopefully be able to get to all of them. In the event that we cannot, however, we will invite you to submit your questions via email, and I will give you that information at the end. So, a few goals for this presentation. As I said before, we are offering this as an educational session that looks at healthcare reform and the specific Medicaid reform legislation in Florida, helping us all to think collectively about what opportunities exist for us and what challenges lay ahead. So clearly, we want to be able to present the key features of national healthcare reform in objective and clear terms, think about with you what some of those potential benefits as well as the challenges of implementing the new law might be. But as I said before, we do want to take a special little snapshot of what's happening in Florida regarding the new Medicaid reform legislation and what it means for the state as well as what it means in the context of national and state health reform. And then finally, at the end, we'd like to provide some recommendations or action steps, if you will, to think about how we might address those challenges for Florida. So if we could have the next slide. And I would now invite Dr. Meyer to join us.
Thank you, Leda, and thank all of you for joining in today, and look forward to your questions later. As many of you know, Florida has over 4 million uninsured people in the state, and that's out of about 18.5 million total residents. So it's a little more than 1 of 5 people who find themselves without health coverage, and rising. It's been rising, and it will keep rising unless we make some substantive reforms in our system. This long-term problem has been exacerbated by the high unemployment rate, which has been particularly strongly felt in Florida. The unemployment rate is over 11% in the state, a good 2 percentage points above the U.S. average, which itself is very high. So people are losing their jobs, and with their jobs, frequently, sadly, they lose health coverage. And in addition, there's a lot of pressure on the business community, particularly small employers, to drop coverage or cut it back to employee only, or make other reductions in covered services. And if you lose your job and lose your health coverage in a state like Florida, it's very difficult to get any help from the public sector. Eligibility for Medicaid in Florida is very low. In fact, it's as low as 20% of the federal poverty line, and that means that a family of 4 in the state that has an income as low as $5,000 per year, not much for 2 adults to feed their family with 2 children, they still are deemed as having a little bit too much income to qualify for the public program. So this is a particular problem. Next slide, please. Going without health insurance has direct costs, but also very indirect costs. And the point I want to stress here is that all the residents of the state of Florida are paying for the uninsured and the underinsured one way or another, either through higher insurance premiums or through higher taxes to support growing public programs and enrollment there, or through higher prices as the business community passes along the cost to consumers of its products and services. We also know that this places a great burden on and doctors who are serving a lot of care, and that there are indirect costs as children get sick, get more complications of chronic conditions like asthma that flare up when they're not getting the proper treatment because their family can't afford it. They miss school, they fall behind, and this can hurt them over a lifetime. Adults who are uninsured don't have a regular source of care. They have difficulty affording prescription drugs. They don't get, not as likely to get frequent and regular checkups for preventable diseases, and they get late-stage diagnoses of cancer and other serious life-threatening illnesses. They're also off the job a lot more and miss work, and that lowers productivity and increases absenteeism. We estimate that the indirect costs can be as high as $8 to $17 billion a year when all these economic and social factors are brought into the equation. And so we really kind of look at healthcare reform as a smart investment to provide upfront coverage for preventative care, primary care, early care that will pay dividends later on in terms of a healthier population and for the people that will be paying taxes instead of draw down benefits. And smart governments work with the private sector to make these kind of intelligent investments. You know, it's somewhat like public education and private education. We know that an educated child will be a more productive adult and earn more money over their lifetime and have a better life. The same is true of healthcare. We should view this as an investment in what we call human capital. Next slide, please. I'm going to just mention, if we could go to the slide, some of the key components of health reform. I'm going to mention Medicaid expansion, health insurance exchanges, insurance market reforms, requirements on individuals and employers, and how health reform is paid for, the financing of it, and some of the grant opportunities from the federal government that could improve quality of care and help manage costs in the state of Florida. I want to emphasize that health reform is fully paid for, and I'll explain who pays for it because it's not free. And the insurance market reforms in particular will help people who are sicker or older workers and make sure that they're not screened out of coverage and turned down or priced out of affordable coverage, as too often occurs under our current system. Next chart, please. I want to concentrate now on Medicaid. What would happen if we implement the new health reform plan in Florida? What will happen is that at least 1 million and maybe 1.4 million people would be eligible to enter Medicaid, and my colleague will explain some more about that in a few minutes. The majority of these people, about 3/4, would have not been covered before, and this will be coverage for the first time. State would have to invest about $1.25 billion to $2.5 billion over a decade in order to pay their share of bringing people into Medicaid. But this would draw down well over $20 billion over the decade in federal contributions, or at least $10 new in federal money invested in the state of Florida for each dollar that the state puts up. In fact, for the newly insured, who are the great majority of the people that would get coverage, Florida would get $25 in federal money for each dollar the state puts up. This is a good way to leverage your money, and we think that intelligent people across the political spectrum want to make this kind of investment in getting people covered so that they're healthier and more productive. Next slide, please. Now I'm going to turn to Laura, who's going to tell you a little bit more about this Medicaid piece.
Thanks for that overview, Jack. And let's just take a little closer look at who will be impacted by the Medicaid expansion provision of the Affordable Care Act in Florida. So, this is really good news for the uninsured in Florida. The expansion of Medicaid is significant because it will be the largest new source of coverage for the uninsured in our state. In fact, it has the potential to cover 1/4 of Floridians who now have no access to care or have no access to health care coverage, I should say. The new income level will increase to 133% of the federal poverty level, which is about $30,000 annually for a family of 4, which again is still very low income, but it is a significant increase, especially if you look at these various eligibility levels for different groups. As Jack mentioned, adults and parents are at 20% of the federal poverty level. So we'll definitely see the largest increase amongst adults and the most significant increase amongst childless adults who for the very first time will be eligible for Medicaid in Florida. Now, children are eligible at 200% right now, and that will remain the same. However, Florida really has a very low insurance rate of children, and even though we have a 200% eligibility income guideline, there's significant barriers continue to exist to enrollment and retainment that really need to be addressed now, and certainly within the context of the implementation of the federal health law. Now, it should also be noted that as we see a rise in the Medicaid population, doctors treating Medicaid patients will also see their pay increase, and their reimbursement rates will actually be increased to Medicare levels starting in 2013. And so this is important because when we think about all these new people coming into Medicaid, we need to make sure that there's doctors to provide care for them. And I know Jack's going to talk a little bit more about this. This would expand access to care. And the increase in the reimbursement rates is paid for by the federal government, not the state. Next slide, please.
Well, thank you. We want to focus also on the hospital sector in the state of Florida. We have collected data that shows that Florida hospitals are providing about $3 billion and growing of uncompensated care. This is free care, bad debts from people usually that are uninsured or very underinsured. We believe that at least $1 billion of this $3 billion and maybe more could be saved from health reform as more people come into a hospital with a source of payment. What's happening in Florida and some other states is that the hospitals are becoming like the shadow government of the state. They're doing the work of caring for very poor people that should be done through the public sector. But when it isn't done because eligibility standards are so low, then hospitals, and I might add physicians, have to act as if they were a government, which is not what they're set up to do, and provide this free care. And we calculate that even if half of the indirect costs and the direct costs are realized, the sum of those two across all the savings will more than offset the new costs. There are new costs to the state, as I mentioned earlier, but they would be more than offset by the savings if you look at all the players in the system. Next slide, please. I want to mention and summarize some of the benefits. I'll talk about the challenges in a moment, but the benefits to residents of Florida from health reform. First of all, $1 invested in prevention and primary care will translate in many cases to fewer dollars paid out at the back end. So $1 invested in the front end will reduce spending at the back end. We know this from endless amounts of research, and I've just mentioned some of the reasons for that. People will not be hospitalized for flare-ups when their child has asthma, or going into a coma if they have diabetes when they don't maintain their care. And they won't be cycling in and out of the emergency room at tremendous cost. That can be averted in many cases if people have health coverage, they have a regular source of care instead of using the system randomly. They nip problems in the bud and get preventive treatments and primary care from a regular source. This will improve their health, it will improve the economy, and it will save total costs if we emphasize prevention, early screening, and intervention. And it will remove some of this burden on the doctors, hospitals, nurses, and labs and other players in the healthcare system. And it will help the business sector and people like you and me that buy their coverage from private insurance companies, because a portion of our premium that we share with our employers or pay on our own is to cover that cost of uncompensated care. It's the cost of neglect and delay. Next slide, please. Of course, where there are benefits, there are challenges. This is a heavy lift. And one of the challenges that Florida will face, along with the other states, is assuring an adequate health care workforce. We're going to bring more people into the system, and we're going to have the doctors, hospital beds, nurses, nurse practitioners, and physician assistants to serve these people. This is a particular problem in the Medicaid program where Florida, like most states, I'm not singling out Florida, has tried to save money primarily in the past by lowering payments to doctors and hospitals and other players. Hopefully this will be improved in the future. We do have to pay attention to adequately paying for their services, and dentists as well, huge shortages of dentists, to make sure that our kids and our adults have a place to go. It isn't enough to hand them a card, an insurance card. They have to have a doctor that can see them. And we also have to recognize that poor and near poor adults who would be coming into care for the first time in their lives include people with multiple chronic illnesses. It might be congestive heart failure or chronic obstructive pulmonary disease, and very high incidence of behavioral health problems, mental health, substance abuse, and even some homeless people, particularly among single adults living in poverty. And finally, but an important factor is that even though a dollar spent by the state can be leveraged to pull in many federal dollars, the state will still have to find a way to come up with that dollar in a very tight budget climate. I'm not naive on that, it's hard to invest at the front end if you're in a state deficit, and I know that the legislature and the executive branch are working to reduce that, as are all states. Next slide, please. I want to turn now to talk about health insurance exchanges. These are a kind of insurance marketplace, or farmer's market, if you will, set up under health reform for people now above the new expanded eligibility levels for Medicaid, who are moderate and middle income people, people with incomes of $35, $40, $50, and $60,000 a year, even up to 70 or 80 for families with 4 or 5 people. These people would be able, and these folks now frequently are uninsured, or they have only a choice of one plan, and they may have to buy it on their own if they work at a company that doesn't offer it. They would be able to go into this marketplace and get an array of plans offered to them, many different choices. They'd all have to be comprehensive coverage. There would be a premium subsidy from the federal government, federal-only dollars, if their incomes justified it. And unlike our current tax subsidies, which are worth more to a family the more they make, which is exactly the opposite of what we should be doing. So when your employer buys health care for you, you don't have to count that as income, and the higher your tax bracket, the more that's worth to you. Quite the opposite in the case of the exchanges. The less money you have, the more subsidy you would get. And the exchanges would also offer a single point of entry where, with federal help, states could determine who should go to the Medicaid and which kids to chip and who's directed to the exchange. There will be a federal hub that states can plug into and check income and eligibility. I might add that undocumented immigrants are not eligible for subsidies, either in Medicaid or the exchanges, but legal immigrants and U.S. citizens are eligible, and that can all be checked. The state doesn't have to do that, but it has to plug into these systems and develop a spoke that could plug into the federal hub. And this is going to take some work. But there's a potential for these exchanges to offer affordable care and to monitor quality, to set targets for participating health plans with regard to diabetes management, such as the hemoglobin A1C test, with regard to many other aspects of following the best practices. A heart attack patient, do they get an aspirin at arrival? Do they get a beta blocker drug? All these things could be evaluated by these purchasers, which would help drive quality improvements in the system. It's my hope that Florida will think carefully about creating its own exchange rather than letting the federal government do it. It could do it within certain guidelines within its own political structure and cultural imperatives and its own unique environment, and make a number of choices to design this the way the residents of Florida think is best, rather than the way that Washington policymakers think is best. But you would have to participate in the early planning. Next slide, please. So in summary, there are a number of benefits to these exchanges. Broader choice. Small firms can bring, those with 100 or fewer employees can bring their workers into the exchange through 2016. Beyond that, all firms could, so this could help small business. And I've covered the other two points, so let's move on to the next chart, please. There's some challenges here. Again, building an electronic system to determine eligibility for multiple programs. This could even include food stamps and cash welfare and so forth. It would be wonderful, and it would streamline the system, and moving toward electronic records, all good, but that takes resources and ingenuity, and Florida will have to start planning. And as well, the law enables states to assess health plans and make sure they're providing the most benefits out of the premium dollar, and that will take a healthy amount of effort to review those plans. Next slide, please. I want to briefly mention insurance market reform. Some are already in place. No lifetime caps on benefits. I have a good friend that just is at home now after 4 months in Johns Hopkins Hospital. He's doing better, 3 months in a rehab center. I know that his care approaches $3 million. Had he been in a policy with a $1 million lifetime cap, his family would be bankrupt now. This plays out. It's not the typical case, but there are accident victims, trauma victims, and the like who really could be bankrupted. So health reform would address this. It would help many young adults in Florida who complete their schooling and haven't yet been in a position to afford buying coverage on their own, stay on their parents' policies till age 26, and address such things as pre-existing conditions for children so that parents can change jobs and so that kids can get the care they need and not be screened out. Next slide, please. There are more insurance reforms coming. I'll be very brief here in the interest of time, but the basic idea of this first point in 2012 is to require insurance companies to pay out at least 80% of the premium dollar in either benefits or quality improvement initiatives. So in other words, this recognizes that they do have administrative costs and can earn a profit or a surplus, but there's some limits on that to try to get as much as possible of the premium dollar in actual medical coverage. It's a little higher for the large employers. And when these reforms are phased in, there'll be limits on how much insurance companies, how much more they can charge older people than the youngest, 3 to 1. Today it's often 10 to 1. And they won't be able to charge women more than men. And that's, you know, in America, being a woman is a pre-existing condition. And that will end, and no annual limits on benefits. Next slide, please. This will obviously help many people. I've covered some of this, so I'll be brief. But children with disabilities would be particularly benefited by these insurance market reforms. I've mentioned young adults. There are also provisions that your insurance company, and these are in force now under health reform, can't suddenly drop you 4 months, 6 months, 10 months into expensive treatment for diseases like cancer because they go back to a form you might have filled out 5 or 10 years ago, and question 8, you accidentally got that question wrong. They would have to prove that you intentionally committed fraud. If you did, of course, then that's another matter. But these forms are complicated, and it's been prevalent in some circumstances that insurers have dropped people right in the middle of their coverage. So that's another benefit. Next slide, please. Again, where there are benefits, there's some challenges, and in order to keep down premiums for older workers, younger workers' premiums may go up. They may be inclined to say no thank you, and we need these younger workers in the insurance pool in order to make sure that costs are held moderate. We can't just have it be for sicker and older workers. There are penalties in the reform plan for not complying. Those are being challenged now in Florida and elsewhere, but it still may be a problem regardless of how that comes out. And states will have to engage, as I said, in a good bit of review of health plans and insurance company characteristics and their premiums, and make sure those premium increases are reasonable and affordable, but do so in a way that doesn't chase insurers out of the state, which is obviously in nobody's good interest. Next slide, please. There are a number of federal funding opportunities. The new law contains $11 billion over 5 years in new federal support for community health centers. Florida has 44 federally qualified health centers and quite a number of free clinics that could apply for this money. This could help them open a new wing or stay open later or hire an additional doctor or nurse. It can make a critical difference to modernize, go to electronic health records. So this is critical that Florida participate in this opportunity. There are a number of other demonstration programs related to Medicaid that the state could apply for, and Medicare, new approaches to paying doctors and hospitals to try to give them incentives to manage costs better and to improve outcomes, and to get physicians and hospitals working together with rehab centers to manage the money under one roof so they don't just pass along the patient to the next system, which is not good for health care and not good for costs. Employers can benefit too from workplace wellness programs where they receive a tax credit, and there are other aspects, also premium tax credits of up to 35%, and that's enforced now if they offer coverage. Next slide, please. There are, and this aspect is controversial, a number of individual obligations under health reform. Small companies with 50 or less workers are not required to offer coverage, although if they do, they get a credit, as I've said. But businesses with 50 or more must either offer, they're not required to offer, but they must either offer or pay a fee. And larger firms can come in later, and even larger firms with 200 and more employees, if they decide to offer health coverage, must automatically enroll their workers unless the workers positively opt out. It can make a big difference in participation. And of course, you're aware of the individual obligation with some modest penalties, but it is an obligation that's being challenged by Florida and other states, working its way through the court system. Next slide, please. All these benefits have a cost. They have to be paid for, and here's a brief review of how that's done. Participating providers in Medicare, hospitals, labs, and even managed care plans under Medicare would get a smaller increase than they otherwise would get in order to offset the cost. Benefits are not reduced to the Medicare enrollee, but the providers get nicked. There's a board being set up that would make recommendations if Medicare spending exceeds targets on how to bring them back in line. There's some payroll and income tax increases only on the upper 1 or 2% of residents of Florida and all other states, $250,000 or more of income for a family. There's an excise tax on the most expensive policies, which would be imposed on insurers. Those are policies that have at least double the cost of the average policy. And some fees on different manufacturers of devices, pharmaceuticals, biotech, and health insurance plans, and so on, even tanning salons. I now want to turn it over to Laura. That covers the major features of the law, and she will discuss some of the very recently enacted legislation in the state of Florida.
Thanks, Jack. And so we're going to turn back again to Medicaid, and as you can see, we've mentioned it's a really important part of the health law, and certainly there's been significant focus on Medicaid in Florida and what role it plays in the Affordable Care Act. And I think it's also important to understand just what Medicaid is. It's an integral part of Florida's healthcare system. It currently funds 51% of all new deliveries of babies. It also funds 2/3 of seniors in nursing homes, and almost 1/3 of our children are covered by Medicaid. So while Medicaid currently provides medically necessary coverage for very low-income pregnant women, children, seniors, and the disabled, the expansion of Medicaid will mean that people who have very low incomes and no access to coverage will be able to obtain needed health services for the very first time under the new health law. Next slide, please. So now let's take a look at this very controversial, again, Medicaid piece in Florida, where they recently passed a law that would drastically change the way that Medicaid is delivered in Florida. So it's important to understand how Florida is proposing to change the system because of the important role that it plays in our healthcare system. So this past session, Florida passed a law that would change this, and it would do this by expanding the role of Medicaid managed care in Medicaid and requiring virtually all Medicaid recipients to enroll in an HMO or an HMO-like plan. Now, this proposal builds on a pilot program currently operating in 5 counties in Florida. It's referred to as the Medicaid Reform Pilot, and it's been heavily criticized by a number of groups, including Medicaid recipients themselves in these counties, patient advocates, providers, and external reviewers, including the state's Government Accountability Office, OPAGA, and Georgetown University. And so it's important really to look at these criticisms as Florida tries to move forward with this, because this is really going to, we're going to have all these new people coming into Medicaid, but what type of Medicaid system is going to be there for them? And as complex as the health law is, this proposal's complex as well. So critics point to the lack of evidence from this pilot program that demonstrates that Medicaid reform and expansion of Medicaid managed care with flexibility of HMOs to alter the benefits and services that recipients received, they cite that there's a lack of evidence that this has saved the state money or increased the quality of care. And in addition, consumers, doctors, patient advocates have shared many cases of recipients who are failing to get access to timely or adequate care in these pilot counties. And so it's really important that we look at this example as we move forward with the proposal and as we move forward with implementation of the Affordable Care Act. Now, it's important to note that this Medicaid managed care expansion plan that was recently signed by the governor still has to be approved by the federal government, because Medicaid is a state-federal partnership and the funding is shared. And so the federal agency tasked with that job has already, which is the Centers for Medicare and Medicaid Services, has already pointed to a number of issues that they want to see addressed before they approve this plan. And so that's a shorter version of Medicaid reform, but it's certainly much more to talk about. Next slide, please. So just for staying on this Medicaid issue, there's a number of things that Florida really needs to do to prepare for expansion. And here's a short list, but the number one is to really look at outreach and enrollment to cover the newly eligible, and this involves a number of things, but updating and streamlining enrollment systems that need to align with the new insurance market or the exchanges that Jack talked about, and also to align with CHIP coverage and other places that people get health insurance. Now, the health law mandates that there shouldn't be a wrong door. So the state really needs to set up a no wrong door for enrollment. So the state really needs to prepare now for a system that makes this easy for consumers to either log in, walk in, or sign up for health care coverage. They're going to find a way to get that through the various programs. Now, if the Medicaid reform plan that I just spoke about is approved by the federal government, then the state's also going to have to prepare for that, again, meeting the conditions outlined by the federal agency. And the federal agency that will approve this, CMS, has already noted that the involvement of patient advocates, providers, and consumers should be a part of that. And in addition, the state also needs to prepare for new Medicaid recipients that may have medical issues as they've been previously uninsured, and really should take advantage of a number of quality initiatives and funding that's out there to improve upon Medicaid. Next slide.
Okay, I'm going to be very brief here to allow time for your comments and questions. And the point I want to make, the main point, is that exchanges are not a brand new idea. I think they're sort of the heart of health reform, these insurance exchanges. They're not a radical idea, and they're certainly a government takeover. It's a way to organize the private sector marketplace, and these grew out of real-world programs set up primarily over the last 25 years by the business community in many communities and states around the country, including an earlier experiment in Florida, where business coalitions tried to arrange purchasing cooperatives for their small business employees who just weren't, or the small firms just weren't able to get a good deal from the insurance companies the way a self-insured large employer could. There's a long history here. 2 states have been experimenting with versions of exchanges for the last several years. Massachusetts, which has a more expansive model, Utah, which has a more limited model. We can learn from both of those. So this didn't just drop out of the sky, and it is a way, and I think Florida, regardless of how the litigation comes out, and the political debate, which is what we do in this country, which is great. Regardless of that, Florida should consider something like this for its middle-income people and low-moderate income people to have affordable choices. And there's some challenges there, as we've both outlined, in terms of setting up the web portal, learning how to screen populations and assign people to different programs, and how to risk adjust premiums. Some insurance plans, despite the reforms, will attract more of the sick older workers, and others will get more of the healthier younger workers. So there's a mechanism called risk adjustment that would rearrange some of those premiums to help out those that are seeing the hardest to serve patients in disproportionate numbers. All these are challenges as well. There's going to be a challenge to collect data from participating health plans on people with chronic illness and disability so that we can learn how to better manage their care. We have to move from cherry-picking the healthiest patients, which has happened in our healthcare system, to learning how to better manage the sickest patients. That's where the money is spent, and it's on people with disabilities, people with chronic illness, and so forth, people with mental retardation and developmental disabilities, frail elderly. This is what's driving Medicaid, and this is what's driving costs in our healthcare system. So there's an opportunity here for an active purchaser like an exchange to better manage care and work in partnership with the other payers in the community, including private employers. That would be great for Florida. To do this, the legislature would have to enact the authority for the state to start planning. They don't have to make a formal commitment to do it, but just enable the planning to proceed. So in case this proceeds, Florida will be ready. I think it's now time for your questions and comments, which we, of course, welcome.
Thank you so much to Jack and to Laura for your great presentation. We do have about 20 minutes for questions. As I said before, we ask for you to type in your question, and Tracy Lowe will be reading them out so that we can answer as many as possible. Before we go to that, though, quickly, I just want to say if we run out of time and there are still lingering questions, you can email them to us to my address. It's my name, first initial L, last name Perez, P-E-R-E-Z, at thecollinscenter.org. Our PowerPoint for this presentation is up on our website at collinscenter.org, as well as a shorter policy brief on the essentials of this presentation and on healthcare reform in Florida. And finally, you would also have access to the full report that Jack Meyer was also the lead in producing together with the Collins Center. So with that said, let's open it up for questions. Tracy, do we have any questions that have come into you?
Yes. Hi, this is Tracy. First question has a little description at first, so it's a little lengthy. Hang on just a minute. There is a shortage of primary care providers in our state. Nurse practitioners and nurse midwives are seen as a cost-effective way to improve access to health care, and the IOM recommends using them at their full scope to increase primary care. According to testimony by the Florida Medical Association, only 5% of physicians take Medicare. Many nurse practitioners and nurse midwives want to provide primary care, but Florida places many restrictions on them. The ACA addresses them as primary care providers, but Florida restricts their practice. How can we work to remove these barriers to increase primary care access as envisioned by the PPACA?
Well, let me take a crack at that, and others can join in. It's a good question. Yes, I'm sure there's a shortage of primary care providers, primary care doctors, as well as nurse practitioners, nurse midwives. Research on nurse midwives shows that they're a safe and effective alternative to standard hospital births. I think the questioner probably meant and may have said that 5% of physicians take Medicaid. I'm sure that more than that take Medicare, and it's a particular problem in Medicaid. We have tried to put too much emphasis on cost control by cutting provider payments, and it is boomeranged. So the law calls for an increase in primary care physician payments for 2 years in 2013 and 14 up to the Medicare rate, bringing the Medicaid payments up to the Medicare rate. I would like to see that extended beyond 2 years. In terms of, and it also calls for some bonus payments to primary care physicians. But we need that and more. In terms of scope of practice, Florida does, as the questionnaire implies, need to review its scope of practice restrictions to enable highly trained professionals, whether it's NPs or physician assistants or midwives or, for that matter, dental hygienists, to do the work that they can safely do. And they shouldn't be blocked by groups that think that this is competition. We need to have complementary, not competitive, sources in healthcare.
Okay, the next question. What are the possible effects to long-term care or nursing home facilities?
Well, the new law provides what's called the class provision, CLASS, which enables people to kind of pre-fund for long-term care through private insurance, but particularly pre-fund what would be community services that they could receive at home. And this is very important. Many states are looking at moving in this direction. Many have adopted home and community-based waivers in order to pay for adult daycare, meals being brought in, services to help a senior in Florida stay in her apartment, stay out of an institution as long as possible. And Florida should consider working with the federal government to take the Medicare and the Medicaid money and put it all under one roof and manage it jointly. There are a number of options. Also, a federal office in CMS, headed by Melanie Bella, is in charge of these dual eligibles for both Medicare and Medicaid. They've given out grants to 15 states. They said they'd be willing to help other states learn from these 15 to see what best practices could help keep people out of nursing homes and other long-term care facilities. So it's a very big challenge. I think the new law touches on it, tries to improve it, but we really have to have a wholesale change in our approach. And part of that is going to be getting away from forcing people to spend themselves into poverty and lose all their dignity and then go in a nursing home in order to get government assistance. That is not a system that can work for the 21st century. So we need more of a social insurance, some combination of private insurance, public insurance for long-term care. And until we consider some of these fresh new alternatives, we'll still have a welfare-based and a nursing home-based model, which just won't work. The numbers of aging population won't allow for it.
Okay, next question. Doctors today deny service to new Medicare and Medicaid patients. How would the AHCA achieve increased access under Medicaid if the reimbursement to doctors is reduced?
This is Laura, and I mentioned this in the presentation. So starting in 2013, the Affordable Care Act provides for federal funding to increase the physician reimbursement rate for Medicaid and up to Medicare levels. So they may have been asking slightly broader question than that, but that is something that advocates have been calling for a long time, is to increase the reimbursement rates for Medicaid physicians. And that in itself should expand access. I think that there's more that can be done, but that's certainly one provision that will improve that.
Okay, next question. Would you please comment on the activities of Florida Health Choices, which appears to be an attempt to establish an insurance exchange in Florida?
This is Laura again, and Jack, I'm just impressed with your breadth of knowledge on this issue. So if you have something to say, please.
No, you go ahead. This is your sweet spot.
Yeah, well, the Florida Health Choices, I actually just looked at their website today. But, there are requirements for as Jack mentioned, the state can either set up their own exchange or the federal government will do it. But the state has to meet requirements, and they have to, sell insurance in a certain way. And the plans that are available in the insurance exchange have to be good plans, and they have to meet certain standards. So looking at Florida Health Choices right now and the way it's written in statute, it certainly wouldn't meet those standards. So if this program, does launch the way that it says in statute, it just won't be acceptable, and then the federal government would have to get involved. But I would I would say that it does look like, there certainly are plans and that they're moving forward with that, but it's been several years.
Okay, the next question. What does the new legislation, state and ACA, do for healthcare cost and quality?
Well, there are a number of steps taken to control costs. Some people believe not enough, but they're moving in the right directions. First of all, as I mentioned, there are a number of demonstration programs that would try to control costs by giving rewards to hospitals and physicians the readmission rate. Some 20% of people in Medicare who are discharged from a hospital end up back there in 30 days, and half of them had no contact with the healthcare system during those 30 days. The law would begin to give incentives, a gain-sharing arrangement to hospitals that lowered that. There are also accountable care organizations, which would be networks of doctors and hospitals that would get together and agree to targets to improve quality and lower costs over a period of a few years and be rewarded through bonus payments by the federal government if they meet those targets. There are also bundled payments to try to get all the payments together under one roof. In addition, the new law, as I said, though it's a delayed startup, would put a tax on the most expensive health plans on insurance companies. That's another measure. And a third approach would be to set up this independent advisory board to make strong recommendations, which Congress would have to vote on an up or down basis, no amendments, take it or leave it, to bring down Medicare spending, which would be hoped that would move to the private sector. On quality, I think we all realize that there's a need to have incentives for physicians and others to follow best clinical guidelines, critical pathways, and the law sets up incentives for them to do so. And both the stimulus legislation from '09 and this law from 2010 also provide incentives and funding for doctors and hospitals to adopt electronic medical records and to move toward a fully wired up electronic system. We know that that will reduce medical errors, particularly in prescribing, but also never events, or leaving a sponge inside of a patient, or terrible infections that are acquired in hospitals like C. diff and MRSA. The new law doesn't solve these problems. I think it's the start down a path of changing incentives and providing positive rewards to doctors and hospitals that really try to follow best medical practices, and eventually some reductions in payments to those who don't fall in line. A percentage point, 2 percentage points, that is also a part of the law.
Okay, next question. Why is it so much better for the state to set up the exchange, especially reluctantly, than to have the federal government set it up?
Well, let me start here. Incidentally, Leda and of course Laura, don't hesitate to jump in. I don't want to do too much of the talking. I think the law enables states to make a number of different design changes that they might want to make differently than the feds would do. For example, do you want this to be part of a state government agency like ACA, or do you want to set it up as outside of that, a quasi-governmental nonprofit? I think most states are saying, we'd rather have a nonprofit and be freed from state governance rules. It allows you to decide, do we want to put the pool for small firm employees separate from individuals who join the exchange, or do we want to merge them? That should be a state decision. Do we want to be an active purchaser, or just more of a web portal? And do we want to allow insurers to operate in just a few counties, or force them to go statewide? All these and more are design decisions, and they also have to figure out under the law, the exchanges, how to be financially self-sustaining by 2015. Florida may want to do that one way, Georgia another. Some states might want to use a tax on insurers, other on consumers. So my point is, I think most states that I've talked to, and we're working with states across the country on this, they haven't got all the answers, but they are making different design calls in consultation with stakeholders that include insurance companies, consumer advocacy groups, employer and labor, business and labor, and they find that most rewarding.
Okay, another person.
I would just, I'm sorry, Laura, I would just add to that. I mean, the key here really is who is involved in the planning, and the people that, receive the benefits of the exchange and participate in the healthcare system, whether or not they're included in the planning process. And it should also be noted that, yes, Florida has opposing the law and hasn't really moved on this, but other states such as Texas, they are moving forward on the exchange planning stages.
Okay, another person asked about the website. You can get the policy brief and a copy of the presentation at collinscenter.org, collinscenter.org. The next question, given the tenor of the most recent legislative session in Florida and the suit which has apparently paralyzed forward movement, what incremental steps can be effectively taken to move forward?
That question, I believe, is for me, but can you repeat that again? I'm sorry.
Sure. Given the tenor of the most recent legislative session in Florida and the suit which has apparently paralyzed forward movement, what incremental steps can be effectively taken to move forward?
So one important thing to note is that a lot of these reforms are taking place now, the private insurance reforms. So there's a number of benefits that policyholders are seeing now. For example, no cost sharing for wellness visits or co-pays for new health plans in individual and group policies, as well as seniors. So there's a lot of benefits that Floridians are enjoying. Number one, because the state doesn't have to take action on a lot of this. The insurance companies, it's a federal law and they're complying, or should be complying. And so I think it's important to note that implementation is moving forward on some fronts. Certainly on others, it is not. As we've seen, there's millions and millions of dollars that the state has turned back that could really move us forward in important ways. We talked about seniors in long-term care. The state initially accepted $37 million to assist elders, and that because there is no legislative authority to work on this, that money has been returned or not being used, and there's a number of examples of that. But I think it all, it boils down to the political will and education. And so the more that people know about the law, and we've seen this in polls, the more they support it and will actively engage their politicians to implement the law. And that's really key here. And that's what we're doing today, is informing people about the benefits that they can enjoy now and that we'll see in the near future.
Okay, I just want to make sure we get these last few questions in before the webinar wraps up. The next question, how may or will this health care reform affect individuals with pre-existing conditions such as multiple sclerosis under the age of 65 already approved for Medicare and Medicaid?
Well, the first way it will help them is, some of these people, in order to be eligible for Medicare, if you're under 65, you have to endure, I can't think of any other word for it, a 2-year waiting period. And then you have to meet a very stringent test of disability. There are a lot of people with conditions like the ones mentioned that are in real hardship. Under this law, they would not have to deal with that 2-year wait. They would be able to go into a health insurance exchange and get a choice of plans who could not screen them out because of their illness. And not only that, would have to offer them a group rate and not charge them 10 times what they would offer a healthier person. In fact, they couldn't be penalized because of their health condition. So I think that would be an improvement for these people. And many of them won't qualify for Medicaid unless they're really extremely poor. So all these people that have moderate and low incomes but not completely under 20% of poverty would really get help through private insurance and eventually Medicaid.
I think it's also very important to note the pre-existing condition insurance plan, which is also in effect now and could be helping many more Floridians. But right now there's an insurance pool that Florida opted not to run that's run by the federal government. And it can be accessed through the website pcip.gov. And if you have a pre-existing condition, have been denied insurance, or even if you haven't been denied insurance now and you just have a note from a physician saying you have a pre-existing condition as of July, can be accepted into this plan. The rates have recently been reduced as much as 40%. And just an example of a plan, a 50-year-old could get a standard plan for as low as $270. And right now, the latest estimate was around 800 Floridians had enrolled, but certainly many more would be eligible.
So on that last note, this is Leila Perez again. I'm going to wrap up and say thank you to everyone. I'm sorry if we weren't able to get to all of the questions, but if you have lingering questions, please forward them to me at lperez@collinscenter.org, and we will be sure to answer them or forward them to Jack or Laura and get you some answers. All that's left for me to do now is to really thank our partners and our presenters on this. To Deirdre McNabb and the Florida League of Women Voters, thank you for your interest in this subject and for co-hosting this event with us. To Jack Meyer of Health Management Associates and Laura Goodhue of Florida Chain, thank you for your very clear and comprehensive presentations. And to all of you who've listened in, thank you so much for your interest in this extremely important topic affecting our nation and our state. We hope it's been useful to you. We hope that the products that we've developed on our website may be of service to you. And please don't hesitate to reach out to us if you have further questions, comments, concerns, ideas, thoughts. They're all welcome. Thank you once again, and very good weekend, everyone.